Yes, sir.
Good evening to one and all. I thank the Sahasra ENT Foundation constituted by Dr. Sriharsha and Dr. Bhargaw. They are doing very good human service during this COVID break and then entertaining and keeping us engaged in this Corona lockdown period. And I thank him for giving me this opportunity to share what all I have done in this particular field of ENT, which when we were doing it was not very well taken up because of some aura around it or some situations around it which we are hesitant to pick up. Now with my experience as a beginner and what little effort I have done to get what all I have learned, I am excited to share with you all so that the field of rhinoplasty will be a part of, which is a part of ENT, will be taken up by all in due course. So now this part, as you have been told, is divided into two. The next week we have another part in which the surgical part will be taken care of. So the nose occupies the middle third of the face, which is the most prominent part of the face. The nose, as we have been growing up with, has given some importance as if some honor and character is attached to the shape of the nose, to the size of the nose as it befits the face. So indirectly what happens is the individual will begin to think that his appearance in a social gathering has got a bearing on what he's telling, what he's doing, and his social outcome and his success in what all endeavors he has been doing. Sometimes the nose has also been given a sinister behavior, like a hawk-like nose is told that that person will be having a behavior which is not really worth sincere. Sometimes that is taken care of, which is not really true, but this type of feeling will bear the behavior. So now there is some aura around rhinoplasty as a surgery. All other surgeries, everybody, most of us will be willing to learn it quickly because there is no something attached. What is that something? That something I called aura. And I want to share one interesting aspect with you. As I was preparing this slide, I put these three words around rhinoplasty and I was playing with it. I found that I can make a triangular shape. So this is basically what we are trying to achieve in the patient, a triangular shape in the nose, which is symmetrical, harmonious. And this nasal pyramid, which we all know, occupies the middle third of the face, which I am going to elaborate. So why is there aura around rhinoplasty? It is an art or a science. Initially, when we start learning, it is a science because there are so many angles, so many dimensions involved. But as we see all the doyens of rhinoplasty doing their surgery, it sometimes becomes an art because they have mastered the science so much that they are able to convert the operation into an art with which the patient will be feeling very much benefited. So I call it a revealed operation. In this operation, the results are revealed to everybody, to the attendants, to the patient, to the surgeon, everybody. Because the results are seen easily, the initial learning phase, there will be a sort of hesitation to take it up easily because sometimes the patients are dissatisfied with some small angles or any discomfiture, and which if they keep complaining, so I have come across many people who says they have begun, but after that, then they begin to get little disheartened. The only thing we have to learn is persistence as we keep doing it. The wound closure, as I have been told, is the signature of the surgeon. A perfect wound closure will give an impression that everything inside has been done properly. Like in this case, when we can see that the wound has gone into hypertrophied scar, the wound in this case is because it is in the neck, does not carry much psychological overtone to the patient because it is in an area which is not very prominent. Suppose the same thing happens like a deviated, persistent, or a shape of the nose which has not been corrected properly on the nose. The results will make us little worried about what is happening. So a perfect wound closure in rhinoplasty or a perfect result in rhinoplasty is the one which is going to make us take it up more and more. So it needs a really long learning curve under a good guidance, and people who have been doing fellowships right now will be given long guidance so that they can learn under the masters. So once we get a gratifying result, even though it could be 10%, 20%, 30%, it has given me motivation to learn to do more. So this motivation to do learn more has given me this chance to share my experience with you. So now what are the objectives? The objectives are to make a nose which is acceptable to the patient, functionally also comfortable. So now the objectives, instead of putting it in words, I have put it in pictures. On the left side of the picture, you see the patient who has presented to me. On the right side, this is the photograph of the patient after 1 month after that. Then once the result is good, then the patients are lost for follow-up. As you know, all my surgeries are done in a government setup where the patients come just because of problem and there is no real follow-up, because once they are satisfied, they don't want to come back. This is another patient who has got a prominent deviation on the front of the face, and you can see that this is what I could achieve with results. And this is a nose which, when we took the photograph on the left side, was in the hospital, and outside, when we asked him to, he's not coming for follow-up, I asked him to send a photograph for follow-up. This is the way he looks now. And this objective which I have placed, expression of the eyes will tell you the success of what little we have done. On the left side, there is a vacant look, there is an open mouth, and because of that, the patient was dissatisfied. And on the right side, what little I could do, the change in the expression of the eyes, the closed mouth, and the overall appearance will give you a satisfaction. It has given me a satisfaction that I have to learn about it more and more. So, with these objectives, how we achieve our aims. So for this, like any other operation, we need to assess the patient before surgery, before taking up for surgery. For that, basically, we need to understand the anatomy, the lie of the nose in the face, the relation of the nose to the proportions of the face, the various angles from various views, which I will slowly elaborate one by one. So there is a terminology in rhinoplasty which is special for the various points on the face. On the lateral side, the profile view will tell you the trichion, the hairline, the glabella, the most prominent part of the forehead, the nasion, which is the just below the glabella, rhinion is the center in the bridge of the nose, the supratip area, the tip area, the subnasal or the lower part of the nose, which also comes under nasolabial angle, then the superior lip, the opening of the mouth is called as stomion, and the inferior lip, the mentolabial sulcus, the ogonion, which is the prominent part of the chin, the menton, where the chin sits into the neck, and the cervical point. All these will have to be proportionate to give an overall appearance to the face, which definitely needs a long, dedicated learning process. Then anatomy of the nose for rhinoplasty. To need a good result, we have to find out what exactly is normal, what is the deviation from abnormal, and how to correct it. So as I have told you before, this is the glabella, and then we come to the dorsum of the nose, the tip of the nose, the columella, the margins, ala, the nasal opening, and the philtrum, the upper lip. So the coming to the underlying structures which I have labeled in the previous diagram, we can see that the nasal bones forms the nasal upper 1/3 of the nasal pyramid. These nasal bones are attached to the frontal nasal process of the frontal bone. The frontal process and the maxillary bone gives rise to this process. The nasomaxillary suture line we can see here. Then these are the upper lateral cartilages which are attached to the septal cartilage. Then this is the lower lateral cartilage which has a lateral crus, the dome, and the medial crus. There are some sesamoid cartilages This rim is called as the pyriform aperture. And a special area in the ala of the nose called as a soft triangle, which does not have any underlying structure, only the skin outside and the skin inside form a soft membranous area called as soft triangle. This triangle is very important because when we are doing external rhinoplasty, an incision should not go into this because postoperatively while suturing it may cause notching. So this is a girl who has got a soft triangle on both the sides which are little prominent. So we have to be careful at the time of reassessment whether this notching is unduly prominent, so that while placing the incisions inside, that has to be taken care of. So now, what is a normal nose proportionate to the face? So now the frontal view is divided into three parts by a line drawn along the line of the hairline, another line along the glabella, which is the point of the forehead. Then there is another line drawn horizontally at the basal level of the nose. This divides the face into three parts. So as we can see, this 1/3 is equal to this 1/3 and equal to this 1/3. So the nose occupies the center of the face, which is exactly in the third. So if it has to be beautifully and appeasing, pleasant, it has to be within this. If we divide the nose into fifths, 1/5 on each side, this is one whole, and divided by vertical lines, 6 vertical lines into 5 parts. The part from this to this, the intercanthal distance, the medial canthus and the lateral canthus, the medial canthus from this to medial canthus on the other side, the distance from medial canthus to this, and the lateral canthus to the lateral most part of the pinna, all this being equal, the nose is divided vertically by this line so that the ala of the nose should lie within this area. So that is a nose which is pleasing to look at. So what are the types of noses which we get? So there is a physiological basis which we have gone into the literature. Then if there is a somebody in the area, more air will go inside, and during summer, so because of that, the nose will be larger. In a cold area, the nose is supposed to be smaller because it has to humidify and also warm the air. The shape of the nose is dependent on this. So based on this, we'll find a nose which is along the line in the mid-fifth, a long, narrow, and a nose which is called as leptorrhine. Then as you go from left to right, then we come to a nose which is called as platyrrhine. This platyrrhine means the ala of the nose is much wider. It will be little crossing the medial canthus on this side. So in this case, in a nose like this, the ala, if it touches or just goes beyond, is supposed to be normal. So while doing corrections, we have to take the individual's race, where he is belonging to, and the proportion of the nose to the face. This is called a leptorrhine, this is mesorrhine, and this is platyrrhine. Platyrrhine means flattened nose, where the dorsum will be much flattened compared to a dorsum on this side. So these are the graduations from left. So this type of nose has got the ethnic considerations which we have to take into account when we are doing surgery for the patient. So coming to the leptorrhine nose, it is seen more common in cold climates. Some people in the literature also say that it is also seen in the dry climates because of inflow and outflow of air. In the cold climates, why it is supposed to be narrow and long is during winters, the inhaled air has to become warm and then humidification. If it is narrow, then the time taken by the inspired air to go inside will make it warm. That's why you see a narrow nose. The noses are much more projected compared to other nose. And I find this, that the countries away from will have a leptorrhine nose. And this is usually called as a Caucasian nose. A mesorrhine nose is a part which is little wider compared to leptorrhine nose. The dorsum is in size. The bridge is also, compared to the leptorrhine nose, is little moderate. You will have a very projected nose in leptorrhine type, In this, the projection will be less. This is also called as a Mediterranean or Latin nose. Then this platinine is the widest noses available. It allows more air during breathing. So the flow during summer is less. Otherwise, what happens is because of hot air, there will be more drying of secretions. And as we know, the more drying of air secretions may cause rhinitis sicca. So these type of noses are found more commonly nearer the equator because the equator, as we know, has got a higher temperature. So there is alar flare beyond the medial canthus. So this has to be considered as normal. The dorsum of the nose will be little flattened compared to that. These type of noses are seen more commonly in African and Asian regions. Now, after that, then what is an Indian nose? There is nothing like an Indian nose because we have been invaded by so many races in all our history that everybody who has come here has settled down, and because of that mixture of races, there will be a nose which is different, which cannot be labeled as one. So it depends on the area where we are found. If we go to people in the north, Punjab or Kashmir, then where we find that the people have got a leptorrhine nose, where the noses are very prominent, where there are nasal cavities are very narrow. And when we come to the south, we have a platyrrhine nose more commonly. And this type of noses are also found in Assam and those areas because of admixture of races from that side. So the basis of knowing all this knowledge is to analyze a particular type of nose which presents to us. We can be satisfied with what the patient wants and what we are achieving. So now coming to the frontal profile. In the frontal profile, what we have to concentrate on is there is a condition called as facial asymmetry of Romberg, in which if we draw a midline, the right side of the face and the left side of the face, there can be an inherent asymmetry in some patients, which will hamper the perfect achievement of results. So this results will cause a little bit of dissatisfaction because the right side and the left side of the nose, as we say, if there is some asymmetry on this side, even if we have achieved something else, the asymmetry of the face will be making the results little guarded. So now when we read the frontal face, then there is what is called as a brow tip line. In this is a line drawn along this brow to the tip of the nose, will give a pleasing proportion of the nose on the face. So this is a picture, and this is the real patient who has a brow here. Then you can see the brow tip line, which is going up to the tip on the right side and on the left side. The equal alignment of these brow tip lines, which is also called as dorsal aesthetic lines, is the one which will tell us that the nose is proportionate to the face. Then the next two lines, which we have drawn earlier along the lateral wall of the nose to the medial canthus, will give the nose the ala on both the sides and the line along the medial canthus. And the line along the medial canthus. If the ala extends beyond this, then it is called as a wide ala. And in the next proportion, the width, bony nasal width to the alar width, this will be 75%. If there is any discrepancy, then there will be a widening of the nasal dorsum. Then we will come to what is called as a tip defining point. These are the defining points which are achieved by the dome of the lower lateral cartilages. These are the ones which are going to make the prominence of the nose. So when we come to these tip defining points in an actual patient, this is the tip defining point on the right side, tip defining point on the left side. This tip defining point is equal to the bony nasal width if the proper result is achieved. So otherwise, if this tip defining point has got a triangular area, so this tip defining point will shows the orientation of the right and left. Next, in the frontal face, the lower alar margin should be symmetrical so that only a part of the nasal cavity is visible. So this is dependent on the orientation of the tip of the nose. If there is any asymmetry, then that could be because of the differences in the lower alar cartilage, neither right or left, or if there is, this is the seagull in flight, also called as seagull flight. Seagull is a bird which you see around seas, and when it is in flight, these are the two wings of the seagull, this is the body, and if the symmetry is achieved, then it is considered as the tip definition is clear. So now the projection of the nose, when you see from the lateral side, this is the one which will make as a nose prominent or a nose which is short or receding. So this is the one which is going to make the patient harmonious with the nose. This is a triangle drawn on the nose, right angled. It is a 3, 4, 5 triangle in which the distance from this point to this point to the LR base should be equal to 60% of this line. So then the nose is considered as good projection. If it becomes in excess, it is called as an over-projected. If it is less than 55%, it is an under-projected nose. So based on that, there can be an over-rotated nose, a normal nose, or a drooping nose. Like in this patient, you have a nose tip which is nearer the ala is drooping nearer to the upper lip. This is called as a drooping upper tip. So the knowledge of knowing this will be, we have to make the tip projected by putting some strut here so that the patient gets a good projection from the side. So next we'll come to the lateral view of the nose. In the lateral view, the most prominent is the nasofrontal angle. This is a line drawn along this, along the glabella to the nasion, another line drawn along the nasion to the tip of the nose, the rhinion. So this is usually 115 to 130 degrees. This will give us a good idea of the shape of the nose. If you draw a horizontal line from this to the face, this should be at the level of the tarsus. If it is a level above, it is called as high, mid is up to the level, below that is the level of the pupil. So this nasofrontal angle is the one which is also defines the radix of the nose. Here there can be a lower radix, high radix, or a receded radix that has to be seen from the profile view, and then based on that we have to correct. So in addition to that, the level of the forehead also decides the shape of the nose. In these three photographs, the nose, though it appears normal, the receding will make the nose appear in a different way. The little sloping forehead or a flat forehead will make the appearance, and a receding forehead will make the nose appear short. So this also has to be taken into consideration. So this is the radix I was telling you. This radix, this is here, and this is little receded, and this is more receded more. So this will change the shape of the nose automatically. This has to be also studied in pre-analysis. In the lateral view, we will get what is called as a saddle nose, or sometimes we'll have what is called as a hump nose, where the straight line can be broken up by a hump or a saddle. So next angle which we have to read is the nasolabial angle. This nasolabial angle is drawn by a perpendicular line to the horizontal Frankfurt line touching the upper lip. Another line drawn along the L of the nose, cutting this line. This line is drawn from the tip of the nasion to the LR base. It makes an angle of 90 to 150 degrees. In the male, it will be 90 to 95, and in the female, a little more angle is considered a pleasing angle in females. So coming to the nasolabial angle here, again, we see that it is much less than what is acceptable in a female, which has to be 105. So this is a receding tip due to obtended or obliterated nasolabial angle. Then this has to be either corrected by using plumping graft or by putting a columellar strut. Now there is a double break in the tip lobule. So this area is called as a tip lobule. This is defined by a line drawn along the bridge of the nose, another line drawn along the lower part of the ala of the nose. The points of this tangent, this line is the one which the tip lobule. There can be a prominent lobule or there can be a receding lobule basing on this finding. So now there is what is called as a columellar show. In columellar show, there should be a usually 2 to 4 millimeter gap so that the nose looks pleasing from the side. It can either be receded because of deficient formation of columella, or there can be over projection of this alar base into that, so that the nasal cavities are not seen properly. If there is a recession, more of the nasal cavity is seen. If there is a recession of the columella, then the tip will appear unpleasant. Now coming to the basal view, it is again divided into, it's an equilateral triangle. In the equilateral triangle, the sides on both the sides should be equal. The basal view is formed by the medial crest forming the dome, and the lateral crest on this side and the medial crest, and then there is this part of the lower part of the nasal tip is called as the tip lobule, and then it will be 1/3 to the distance from the tip of the nasal cavities to the bottom of the nasal sill. These two are called as nasal sill. Then this part is formed by the medial crest, which stops here, and is attached to the antenasal spine by fibrovillar tissue, and there will be soft triangles here on both the sides. The tip is defined by the dome of the lower lateral cartilages on both the sides. So in this tip, sometimes there will be a projection of the septum on one side, the caudal dislocation, which is seen more prominently on the basal view. Now, after having read all this, then we have to know about the covering of the nose. The skin covering of the nose has got, the envelope of the nose has got varying thicknesses. So the varying thicknesses has to be studied because the results of rhinoplasty are dependent on the thickness of the skin. If we take a Caucasian nose, the skin of the nose will be thin. And if we take a Platyrrhine nose or a African or an Asian nose, they have got thick sebaceous type of skin. So any amount of correction we do in a thin skin will be very, very prominently seen. Even a minor irregularity is prominently seen in a thin skin. If the skin is thick, whatever amount of correct achievement we have done, the skin will camouflage to such an extent that the results will not be very seen clearly in a thick skin. So the orientation of the skin on the dorsum of the nose is thick at the root, thin at the bridge of the nose, and again it becomes thick at the tip lobule. Because of this orientation, the corrections in the mid part are very prominent, and if there is any correction done here, that will take little time to reveal. So the orientation of this skin is important for getting good results. So if somebody has got a thick skin, at the time of giving them assessment of rhinoplasty, we should tell them that the results may not be revealed immediately or even after some time, because the edema will be there. So now, after having assessed the nose, then we have to document it. Otherwise, the results cannot be assessed. What is the result which we have achieved, so that the learning also will be improved and the patient satisfaction also can be achieved. Then if we take this is photography of the nose is for getting a preoperative data, so that there can be comparison after the results. But the expectation of the results also can be given to a certain extent by showing the pre-op data, the parts which can be corrected properly, the parts which may be difficult to achieve, or if there is any facial asymmetry that can be pointed out. So for taking photographs of the patient, we need to have in certain views. So there should be a frontal view from the front of the patient, the right and the left profile views, right lateral, left lateral. There will be an oblique tilted view. Then there should be a basal view and a top view or a helicopter view from the top. And there should be a lateral view while the patient is smiling. So this part is important because there is a depressor septi muscle which is inserted into the columella. There will be slips on either side, and this, when the patient is smiling, will make the tip recede like this. And some people will give as a complaint that when they are smiling, the tip of the nose is going down and they are not happy with the shape of the thing. So this can be done by cutting these slips so that this change in shape of the nose while smiling can be overcome. So while taking a photograph, there should be standard photographic methods, because at the time of surgery and before surgery and after surgery, the conditions, if they are equal, then it becomes easier to compare. So we need to have a 35mm DSLR camera, and a mobile camera can also be used. So what are the differences? What are the advantages of using the two? In a standard situation, the setting should be ISO 120 or 125, shutter speed depending on 125 to 150 shutter speed, reflected covered lighting so that the patient's face is illuminated properly on both the sides and there are no shadows, and the background of the photograph should be non-distracting. Because the mobile cameras have come into vogue, everybody will take a photograph of themselves and then they'll come and try to tell that this is this and that. There is what is called as a fish eye effect on a mobile camera, where the camera is positioned in such a way that some parts of the face will get distorted in that. So the standard position distance has to be maintained to get a good proportion of the face. Ideally, the patient should be sitting about 6 feet from the camera so that that distance is maintained pre-op and post-op to get a good analysis. Then in addition to that, we have to take the patient's consent, whether they will be willing to share their pictures in any scientific forum, because there is what is called as privacy, and some of the people may object to their pictures being shown, and because of this mobile social media sharing of picture will be privacy issues to the patient, so better to take their consent. Nose, as I told you, being the most prominent part of the face, there will be some psychological aspects ascribed to the nose. So some people may feel that the face is good, the nose is good, and whatever work they are doing or whatever social relations they are having, then the success is related to the aspects of the nose. Some people may think that the nose is somewhat irregular or something, somebody is looking at my nose and not giving me work or not being selected for anything. And particularly, the people going to have a normal interaction will have some issues related to the nose. So in this condition, there is what is called as a body dysmorphic disease. In this body dysmorphic disease, the patient or the individual, usually about an adolescent or a female, mostly males, they'll try to be concentrating more on the shape of the nose or their body orientation, their body proportion, and then they'll be thinking about the nose or the body proportions, one part of the body or the other, and not able to really concentrate on their work. So in those cases, we have to make out the patient whether he has got any of this type of feelings with his nose in relation to that. And if they come for surgery telling that my nose is like this, or I want a nose resembling that so-and-so actor or somebody, then we have to be careful, because they will be dissatisfied after the surgery and then make a problem for us. So one of the dictums given by somebody is, if the patient does not smile at the time of consultation, we have to be beware of this condition. Now, because of CT scan and computer analysis, the many computer software have evolved in which the shape of the nose can be recorded prior to that, and then it can be morphed, and then it can be shown that this type of nose can be achieved or may not be achieved. So if somebody is coming with this type of analysis, then we have to be beware, because there are so many aspects to getting the results, like the soft tissue envelope, the technicalities at the time of operation, and the results. So many of the rhinoplastic surgeons will not guarantee any result, and then they'll try to tell you that the nose can be made much better than what it is. So we have done one type of computer analysis with a CT scan in a patient who has come to ENT hospital. A 19-year-old male patient has come. He has got a deformity since childhood, there is history of nasal trauma and nasal obstruction. And on examination, the external deviation of the nose to the right, nasal septal deviation is seen to the left. So this patient underwent multiple images from all the sides, top, lateral, bottom, and then all the investigations were done. CT PNS revealed deviated nasal septum to the right side, and the left nasal bone was deviated to the right. So in this patient, you can see that this CT scan is showing the orientation of the bone, spine. This is a CT reconstruction done with Blender 3D, and it has gone through micro DICOM and under 3D slicer, and it will give you the orientation of the underlying bony structures. This is a CT scan, it shows the deviation. Then the patient is being rotation, and you can see the anternasal spine going to the right side, the deviation of the septum. And then this gives us the dimensions also of the nose. So as you can see, the rotation of the skull by the 3D approach, the orientation of the septum, the anternasal spine, and the dimensions of the nasal bones, which we have measured the dimension on the right side and the dimension on the left side. So this, you can see this. So this will give us an indication where to do the osteotomy, how much to do, and how to get the nose in the center. So I thank Dr. Rahul for doing all this 3D imaging. It was his innovation, and I have shared that knowledge with this. And because of Corona, the surgeries have come down as far as rhinoplasty were concerned. We would like to do this study much more so that we can come out with really standard results from this analysis. So for expectations of data and morphing, there may be some unrealistic expectations from the patients. So as a surgeon, beforehand, it is our bounden duty to inform what can be corrected, what can be achieved, and what cannot be achieved. So otherwise, if the expectations are more, then post-operatively, then there will be a problem with the patient, because they may become violent, and there are instances where a rhinoplastic surgeon has been taken to task. Many court cases may be pending, or some of the rhinoplastic surgeons have been murdered by the dissatisfied patients. So this difficulty or aura during rhinoplasty is making some of the fearsome complications of rhinoplasty. So now, as an ENT surgeon, the patient will come to us along with a cosmetic deformity, a functional deformity. So in rhinoplasty, it is better to make the nose a proper airway organ and also a proper cosmetic organ. For that, we have to need a direct nasal endoscopy, diagnostic nasal endoscopy, and a rhinomanometry to find out the obstruction inside the nose. So with this type of presentations, now I would like to show you some normal presentations which we see in our day-to-day practice. This is the normal anatomy of the nose, the nasal bones, the upper lateral cartilages attached to the septum, the anterior septal triangle, the mid septal and the posterior septal triangle. This is the orientation of the lateral dome of the lower lateral cartilages. This is the orientation. The volume of the lower lateral cartilages will give us the idea of the volume of the tip, and the orientation of this will define the tip abnormalities. So another common abnormality which we see is maybe because of trauma mostly, there will be deviation from the mid away, then a C-shaped external deformity of the nose. So this, along with this break, it will take up the cartilages also deviated from this side, and then there will be a S-shaped deviation, or there can be a deviation which can be linear completely to one side away from the midline. So this is the orientation of the anatomy of a deviated nose. So now we'll discuss about the real patients where when you take this tape, it shows the deviation in the third, where this patient has got a nasal bones which are deviated to the left side. Then another has got almost normal upper third but a deviated middle third where there is a fracture which has made the septum in the middle third become crooked and has led to a hump also to the left side. The tip is pointing to the left side. Then this is an interesting patient which I have seen has got a congenital abnormality of the nose where only the lower third of the nose is involved. The dorsum is not highlighted, and as we can see the child is about 9 to 10 years of age where the lower lateral cartilages have deformed to such an extent the dome on this side and the dome on this side have separated together. Normally they will be separated by a degree of 30 degrees inverted V. If it is much more, then there is a broad bifid tip. This is the tip defining point on this side. There is no tip defining point on this side. This patient needs a proper correction of the lower alar cartilages, which is achieved by trimming the upper alar, lower alar cartilage domes so that symmetry is achieved. So now the other types of noses which we have seen will be a crooked nose, a saddle nose, a broad nose, and a tip deformities. So this is the commonest type of nose which we see in our practice, a neglected nasal trauma during childhood, which leads to a fracture of the nasal bone and the alignment is disturbed and the patient presents late with this type of deformity, the C-shaped deformity where the nasal bones are deviated, middle third is also deviated, tip looks fairly central. But there will be some asymmetry on the right tip and the left tip, which has to be corrected at the time of surgery. This is a broad nose which has presented a post-operative nose in which septoplasty or SMR was done. The patient does not have details, in which this patient complains that post-operatively the patient's bridge of the nose, which should be a long type, we can see that there is no brow tip line, the aesthetic line on the right and left are absent. So this is the preoperative analysis which will give us an indication that this patient needs a support for the septum, narrowing this part and bringing the two together, and if necessary, the alar base should be removed to make the projection up to the medial canthus on both the sides. And this is another congenital abnormality in which we find that the columella is totally retracted. Maybe it's a case of binder syndrome in which the dorsum is absent. It needs a thick skin, and we have to know about the amount of skin available also. In case we are going to put some augmentation here and pull the nasal tip above, then there will be loss of skin cover, which has to be done by plastic surgery approach, where we can do a VY enlargement of this columella so that the patient will have a normal, acceptable nose. And this is another nose which we see normally in our day-to-day practice. A case of septal abscess during childhood or during infancy, forgotten, and has come with this type of depression in the dorsum of the nose. Because of this, the nasal bones are also maybe little hypoplastic, and there will be some widening of the nose because of that. So once we elevate it, there will be sometimes narrowing of this ala by itself. This ala may need to be resected if it is not very proportionate. So this photograph I have taken from my professor, Dr. Ramanjanelu, for whom I am grateful for this. This is a congenital bifid nose, which is very rarely to be seen, where because during the congenital formation, the frontonasal process, the maxillary and the processes, the horizontal divisions will come and unite. And if this does not unite properly, then there will be a cleft on one side. This is the dome on one side, the dome on the opposite side. The patient has got nasal cavities, and this is a congenital nose which needs correction by combined plastic surgery and a nasal approach. Then finally, when we come to the internal anatomy of the nose, because when we are doing some corrections on the lateral nasal walls, then there will be some medialization which are internal obstructions. So the orientation of the turbinates, the septum, the cartilages, all have to be assessed by doing what is called as a diagnostic nasal endoscopy, in which we will try to orient ourselves so that the airway, finally, when the patient is operated upon, has got a proper shape and proper interior of the nose. So I would like to acknowledge for the photographs taken from Paparella Otolaryngology, and I would like to acknowledge the inspiration given by the doyens of rhinoplasty of our country, like Virendra Gaisas, Kshitij Patil, Ulas Raghavan, for making us learn this surgery. And I thank you for your attention.
Is it safe to do rhinoplasty, DNS correction at the same time?
Yes. As the saying goes, as goes the septum, so goes the nose. So for a proper nose, the septum is the foundation for rhinoplasty. There is a tripod concept in which the septum projection, unless it is completely harmonious and equal on both the sides, if a proper septoplasty is not done at the time of rhinoplasty, then the final results will not be proper. So septoplasty and rhinoplasty is advised to be done at the same time, because the crookedness of the septum will not let the corrections of the lateral wall of the nose allow itself properly over a long period.
That's excellent speech, and this is Nandu from USA.
Thank you, Nandu.
Any more bleeding complications with this combined effort, or it'll be the same, no changes?
The next part of my webinar is on external rhinoplasty, where I thought I'll tell about the complications. Now that you have asked the question, the only complications which we are afraid of rhinoplasty is a persistent deviation of the nose post-operatively. All other things can be tackled by a proper ENT or a rhinoplasty surgeon, but the correction of the nose on the table and what we are giving at the time after operation over a 6 months, 8 month period is the only complication which is alarming, which is threatening, which for somebody who is learning. I hope
you.
I answered your point.
Yes, thank you.
Thank you.
Sir, Anand sir, congratulations for an excellent talk, Anand sir.
Thank you, Nagaraj.
Thank you, sir. Thank you very much. Thank you, sir.
Anand sir.
Sir.
What is the difference between the rhinoplasty done by an ENT specialist and by a plastic surgeon?
Good question.
You have asked a question which has gone through social media so much, but I'll answer with my experience. In 2003, I attended a rhinoplasty workshop by Dr. V.P. Sood, the rhinoplasty surgeon in Delhi, who has popularized. He was telling that there is a court case in US. They have gone to the court. The US court has decided that rhinoplasty can be done by an ENT surgeon also, because, as I believe, we do more septoplasties compared to any other person in medical fraternity. Yes. So a septum is the one which is the foundation for the nose. So the person who is mastered septoplasty does not need much experience to correct the lateral wall, because nasal bone fracture also we have been doing. So if you ask me, the best person to do rhinoplasty is equally a plastic surgeon who has learned septoplasty, or an ENT surgeon whose baby steps are with septoplasty. And for him, rhinoplasty adding to septoplasty is only a little application of his mind. The only thing is, once the success comes to you, there is nothing which succeeds like success. Once we have corrected a nose, which without our knowledge you have corrected something, you feel like doing it more and more. So there is nothing like only rhinoplasty should be done by plastic surgeon.
From the lecture you gave, it appeared that we know what is the structure, what is the function of the nose and the surroundings. I think the plastic surgeons don't know much about the functional aspect of the nose. They know the cosmetic aspect more than the functional aspect. And I believe that the experienced rhinoplasty ENT surgeon will do better job, both functional as well as cosmetic. That is what is shown by Dr. Vishnu Swarup Reddy and others in Telangana, and you are added into that list. I congratulate on your very good presentation and enlightening us and
Thank you, sir.
encouraging and motivating us.
Thank you, sir. But
Thank you, sir.
in this lockdown, I am going through all the webinars all across the world. The perfect rhinoplasty surgeon is one who has done both internal and external assessment. The plastic surgeon's facial plastic surgery course gives them both orientations. So as I told you, the surgery begins like science and then it becomes an art. Initially, we can go about what we are doing by measurements, but after that, the measurements will become secondary, and the leading exponents of rhinoplasty in the world are getting both internal and external results. So it is nothing like that only we should do or only anybody should do. There should be somebody who should able to deliver the goods preoperatively, postoperatively, both by function and by cause.
I think with your presentation, many people, especially in government ENT hospital, learned the technique, the art of rhinoplasty. And I wish we have so many ENT surgeons in ENT hospital, government ENT hospital, Hyderabad. I wish many people will become rhinoplasty surgeons also.
It is only the fear complex. Once the fear complex is gone, then it is easy.
Thank you,
There's
sir.
one question from the audience, sir. Can we do rhinoplasty in case of sinonasal polyposis?
There are two schools of thought here. Some people would like to do the sinus aspect first and then go for a rhinoplasty later. But there are some people who are willing to combine both sinus surgery and rhinoplasty together. So it is left to the person who is doing it, because when we are doing sinus surgery, we are not really doing anything to the lateral wall of the nose. So if it is a limited middle meatal antrostomy, or if it is a limited anterior ethmoidectomy, where we can go ahead.
Dr. Anand Acharya, sir.
Sir,
What went wrong with Michael Jackson?
good evening, Dr. Bajaj.
What went wrong with Michael Jackson?
Michael Jackson, as I told you, the ethnic considerations in my talk. There are 5 types of stages during rhinoplasty. Stage 1 is a nose which is deformed. Stage 2, stage 3, stage 5. You take topmost aquiline Greek type of nose, as they call, a perfect nose. You cannot, or rather, we cannot make a nose from stage 1 to stage 5 all at a time. You can go from stage 2 to stage 4, that is considered a very good achievement. Stage 2 to stage 3 is an average one. The aim is to make 2 stages above. In case of Michael Jackson, as I told you during my talk, ethnic consideration. Ethnic consideration is you cannot change a shape of a nose from one race to another race. Michael Jackson is, though he was there in US, he wanted a white type of nose. And I believe he went about 13 or 14 types of operation. there are skin loss, skin necrosis, but those are the things which should be guarded at the time of surgery.
Thank you.
Thank you.
I request the audience to unmute and directly interact with sir if they have any questions.
Hello.
Hello.
Good evening, Anand.
Good evening, Jagdish. Good evening.
Anesthesiologist.
Yes.
Excellent talk on about preoperative assessment.
Thank you.
But as an anesthesiologist, whether it is done by ENT surgeon or a plastic surgeon,
Yes.
as an anesthesiologist, I am more concerned about counseling for the patient from the first contact with the patient till the patient is taken onto the operation table, about unable to breathe through the nose after the surgery is over.
Yes.
Right? And as you keep telling them in your every visit,
Yes.
patient gets into his mind, and when he wakes up, it doesn't create problem for the anesthesiologist. That is my request.
Thank you, Dr. Jagdish, for your suggestion. I will tell you my what I do. So what I normally do is before I start my surgery, when the patient is conscious, the anesthetist takes the picture, I'll keep packs in the nose. I'll make him breathe through the nose.
Excellent.
Breathe through the mouth, sorry. I keep packs in the nose when he is conscious so that he'll exactly is to be done after surgery. So that suggestion during my practice for the last 20-25 years has given me the ability to overcome the problem which you have rightly pointed out. So that we keep telling them, because we keep doing septoplasty so often under anesthesia, that we keep telling them that you have to breathe through the mouth. Because as you know, breathing through the mouth, it has to be learnt. And a person who is normally used to breathing from the nose will have difficulty little, because in a case of rhinoplasty, because of septal deviation, as it is, he'll be doing some mouth breathing. So in those cases, the problem which you have encountered is definitely there, and we'll try to definitely overcome that.
Thank you.
Thank you.
Sir, we have a question from the audience. How do you assess if patient has tissue loss, and if there's any need of prosthesis, and if it can be corrected by patient nose itself, or add on if you need to add on anything?
So the first base which we have learned is try to orient the patient's tissues himself in his own body. As far as possible, we try to avoid any type of foreign material, even though they tell us that it's non-reacting, it can be there for a long time. The prosthesis or anything in the nose will be, over a period of time, become conspicuous, and it may get rejected. And then there are many instances of Medpore grafts or other grafts put on the dorsum of the nose, which have caused necrosis of the skin. Suppose, as the question says, how do you preoperatively assess if patient has tissue loss, need of prosthesis? So as we analyze the thickness of the skin on the nose, preoperatively we assess the mobility of the skin. On the dorsum, at the level of the nasal bones, the skin is very lax and very supple. Over the tip and over the middle third of the nose, the skin is little tighter, tightly adherent. If there is any loss of skin anywhere, or if the internal skin is also lost, then the repair of that skin which is lost can be done from the conchal cartilage like a composite graft. as far as possible, try to avoid putting a prosthesis. If there is any loss of tissue in the internal architecture, the mucosa from the inferior terminate can be used as a free graft to repair any loss of internal cavity. If the skin is lost outside, it can be from a lobule of the ear to repair any defect in the skin. I hope that answers the question.
Yes, sir. So, from the audience, do you have any questions before we wind up the session? We have a lot.
Excellent presentation, sir.
Thank you, sir. Thank you, sir.
Anand sir, congratulations. Sir, I am Satish.
Yes, sir. Good evening, sir.
Good evening, sir. Wonderful talk, sir. Enjoy.
My pleasure, sir.
Thank you.
Anand, good job. I'm Ramakrishna speaking.
Thank you.
Sir, there's a question from the audience. What can be the contributing factors for recurrent DNS?
DNS, the deviated nasal septum. The contributing factors for recurrent DNS is at the time of surgery, the septum we are doing, most of us are taught first endonasal septoplasty using a headlight, and then nowadays everybody is doing endoscopic septoplasty. So before we take the septoplasty correction into place, we have to find out the attachments of the septum. The attachments of the septum to the maxillary crest, to the perpendicular ethmoid posteriorly, to the vomer posteriorly, to the dorsum of the nose, and the orientation of the septum in the center, whether it is C-shaped or S-shaped. Unless all the attachments other than the dorsal attachments are released, we cannot really achieve a straight septum. In addition to this, we need some corrections. Suppose there is a fracture of the septal cartilage during childhood and the patient comes with a septal spur in the cartilaginous part. So what happens during development, the part of the septum which is growing, there will be an excess of the septum available in nasal cavity. Sometimes I tell them that it's like putting a greeting card in a small envelope. We have to fold the envelope, fold the greeting card to accommodate in the envelope available. The envelope in this case is the nasal cavity. So the greeting card, if you imagine the septum, if you have to arrange it in the envelope, which is the nasal cavity, you have a portion of the septum so that the septum gets into the center. Before you do that, you have to release the attachment along the floor, along the posterior part, remove a part of the nasal bone, which you have to assess it preoperatively, whether it is a cartilaginous deviation, along with that a bony deviation or a pure cartilaginous deviation. Many a times the deviated cartilage will make the bone, the perpendicular plate of the ethmoid and the vomer also deviated towards the cartilaginous deviation side. So unless we correct the posterior bony deviation, either by bringing it back to the midline or sacrificing it, the anterior septal cartilage cannot be straightened. So to prevent a recurrent DNS, at the end of primary septoplasty, without any sutures, the septum should be aligned on the anterior nasal spine and the dorsum of the nose. And after septoplasty, I usually press with the tip of my finger on the tip of the nose. So there should be a resistance to the collapse of the septum. So once we achieve that, then suturing is only to close the mucosal flaps, not to make the deviation septum come to the center. So the contributing factors to recurrent DNS are inadequate release of fixation of the deviated part, proper exposure of the flaps which are on the septum, and removing any bony deviation along with septal spurs or bone. And if there is an anterior nasal spine deviation, that has to be fractured and to really make it correct. And finally, when we are suturing it, we have to put a right suture at the lower part of the septum to the corrected antenatal spine. And if there is any fracture cartilage, that has to be aligned to prevent a reoccurrence. And if there is a deviation which we cannot correct, the ethmoid bone which we have removed can be put drill holes, and then that could be used as a septal batten graft. I hope that answers the question.
Yes, sir. So I think we have come to end of Q&A session, sir.
Thank you, Sriharsha, once again.
Yes, sir. I think that we have come to end of the Q&A session. So thank you, sir, once again for an excellent talk. We have a lot of congratulatory messages in the chat box, and we are eagerly waiting for your next talk on next Sunday, which is
Yes, sir.
be on external rhinoplasty.
Yes.
Thank you.
Thank you. Thank you very much.
Thank you all that, and have a good night.
Thank you. Same to you.